Ladies and gentlemen, dear colleagues, welcome to the ESC 2026. We start this Congress, as always, with the overview of ESC guidelines and document that I have a privilege of co-chairing with the co-chairs of the CPG, the Clinical Practice Guidelines Committee of the European Society of Cardiology. Professor Landmesser and Professor Stefan James. Thank you for joining us. And at the beginning, if you could just very briefly introduce us to the changes and developments that the way that we as ESC develop the guidelines have been happening over the last few years, because you have changed and revolutionized the guideline development. Ulf.
Thank you very much, Tom. And first of all, it's a great pleasure to have this guideline session, and I would like to start with a thank to all the task forces, the ESC guideline group, and all the reviewer that have helped us to develop these important documents. And as Tom Guzik mentioned, for the first time, we will, in these guidelines, you will see a new level of evidence grading. We have now 4 levels of evidence for treatment and prevention of cardiovascular diseases. They are released also in a pocket guideline document together with the other 4 pocket guideline documents, so that you can read and see this very well. This is really an effort to even more precisely define how evidence is assessed and how this leads to a certain level of evidence that we can give in the guideline. And there's also an online webinar for this where you can also see that. So this is, and the documents are also published in the European Heart Journal. So this is part of the endeavor to further develop the excellent quality of the ESC guidelines. And by this, I would hand over to my co-chair, Stefan.
Thank you very much, Ulf. And I'm very happy and proud to be able to present the 2 co-chairs of the first guideline that will be presented, Marianna Adamo and Lars, who will present for us the ESC guidelines for the management of heart failure. This is a very important topic, of course. It affects many patients, and we're looking forward to hearing the news and updates of the guidelines. Thank you.
Thank you, Chairman, colleagues, friends. For Marianna and I, it's a privilege and a great pleasure to present the ESC guidelines for management of heart failure on behalf of the entire task force, which we have to thank so much. These are our declarations of interest, and this is what we'll do in this presentation. We will present some selected highlights. You'll have to go to other sessions to see more details and where you can also ask questions. But I'll start with some important structural changes that had impact on the guideline. And Ulf was actually alluding to this, so I will try to set the stage for that, so if you didn't know, you will understand what he was alluding to. See, the classes of recommendations, they have not changed. It's the same, but the level of evidence has been changed. For therapy and prevention, there's a new guidance published last year in European Heart Journal, and you will see that some will say it will be more difficult to become an A level of evidence. There is more stringent criteria. Secondly, which will confuse some, is that level of evidence B has been split into 2, B1 and B2, where B1 is like one single randomized trial where they have a p-value of 0.05 for superiority, while B2 could be non-randomized studies. And then there is level of evidence for diagnostic test and prediction models. And here we stick with the A, B, and C, and they're not the same exactly for diagnostic test and prediction models. And you see they require another level of evidence. So this is completely different. And for that reason, this guideline this year had to regrade everything that was also there before. So something that was previously class 1 level of evidence A it cannot be changed to B1 without any new data, because that's how we have to grade it now. And that you have to understand that when you read the guidelines. You can also change to 1 to 2A without new data. And the idea is that class 1 recommendation, it should be supported by level of evidence A. So you should not consider this downgrading or upgrading. It's a regrading. And remember, there is a distinction between therapy and prevention and diagnostic test and prediction. So let's move to what's the new. Here's a slight overview of the new concepts. I will go more into details, and Marianna will also, but let's start with the first one. There's been a new universal definition of heart failure, putting less focus on left ventricular ejection fraction. And we've done it more simple. We have removed the heart failure with mildly reduced ejection fraction. So now we only have heart failure with reduced ejection, HFrEF, and HFpEF. And HFrEF goes up to 50%. And we're also saying it's not carved in stone how exactly it is measured. But the implication of this are actually quite a lot, because a lot of trials have not been performed in exactly these criteria. But if you go back and read the old trials, they were not focusing on 40%. There were no trials in 41 to 49. So it is like an interpretation of the existing data. This guideline also put more focus on prevention. So we have also introduced the staging of heart failure, with stage A at risk for heart failure and stage B pre-heart failure, where you have some evidence that something is wrong, structural abnormalities, abnormal cardiac function, but you don't have heart failure. Stage C and D are the classical heart failure things. We've put in a lot of recommendations which have been new or revised for prevention. We will not read them up, go to the other sessions to see them, but you will see if you look on the right side for the level of evidence, you'll see there will be B1s and A's and C's. So there will be changes, and you also see how we have revised some of the older class recommendations. We also put more focus on natriuretic peptides in the diagnosis of heart failure, combined with a lot of imaging specific for different parts of the heart failure diseases. What is also new is a new nomenclature, and you'll probably hate us for this, but we decided to make a new nomenclature for heart failure therapies. We determined that we would have something, remember the color grading here? Green means class 1, yellow means 2, class 2. So for the treatment that you should give to everyone in general, the foundational medical therapy, we have introduced FMT, or for what you add on is AMT, and then we also have one for interventional therapy, and I'll spend a little more time on all this. Why didn't you just stay with GDMT or GRMT? Actually, people do not know what it was actually meant. It's interesting. ESC says we should use GRMT when you write a paper. Everyone says GDMT. But what is it? We realized in the committee that heart failure specialist does not agree. Is it what a guideline is recommended? Well, they're recommending a lot of things. Also with a class 2A, that doesn't make it GDMT or GR. So we thought we'll change this and say, okay, we need to make people aware that there are therapies you should give for the general heart failure patient, foundational therapy. That's why we introduced FMT. And FMT is the class 1 recommendation for the general heart failure population. And it is expected to be dynamic. So, what is FMT today? Will, with an update of a guideline, maybe introduce a new treatment, or a treatment could go from additional medical therapy with more data to become foundational. This should be given for everyone in principle. And AMT is where we have class 2 recommendations, or we have class 1 recommendation, but based on softer endpoint, not morbidity and mortality, but on symptoms of quality of life. Then we would say it's a class 2, it's a additional medical therapy. How do we illustrate this? This is the central illustration in the guidelines. And if you look on the right side of the slide, you'll see you have the green bars up here for FMT. And not surprisingly, it includes ACE, ARNI, ARBs, beta blockers up to ejection fraction of 50. And above, you also have SGLT2 and MRA for the entire spectrum of ejection fraction. And below, you have the additional medical therapy. You could say, why is loop diuretic not an FMT? Because you should only receive it if you have signs of congestion. And then you can see everything else we put in the medical part. And if you move to the bottom part here, you see the third terminology, guideline-directed interventional therapy, where we put in the important intervention you need to consider: ICD, CRT, a new valve, a mitral regurgitation intervention, heart transplantation, LVAD, a lot of things. How does this translate with the new classification, grading system, and nomenclature into the recommendations? I'll give some examples. Here we have FMT recommended irrespectively of ejection fraction. And as you saw on the central illustration, that is SGLT2 and MRAs for everyone. Class 1A recommendation. For HFrEF, you can then also add beta blockers and ACE, ARNI, or ARBs. And an example of AMT could be a cardiac glucoside, digoxin or digitoxin, that should be considered in symptomatic HFrEF patients. This is just an example of the new recommendations in the guidelines. For the DDIT, or the interventional therapy, I've put up the 3 for ICDs, and you see the first one is for secondary prophylaxis, whereas the second one is for HFrEF patients, where it was like the old trials was up to ejection fraction of 35. So we kept the information in the recommendation that this is where the data are. But you see the level of evidence is now a B1 because it's a regrading according to the new system. The guideline-directed interventional therapy on CRT, here is the flow charts of that, and it's literally unchanged, but we put in something new in it, and that is that CRT should probably be planned earlier in a lot of patients. We see patients where we think they will become candidates for CRT, and then we start the FMT, all the drugs, and we start it, up titrate, and wait, and months pass, and then you find out, oh, ejection fraction is still low, then you move to CRT. Our idea is, well, if you think this will end by being a CRT, plan it, but remember to check whether actually the patient improved so much so it wasn't needed any longer. We're just opening a door for planning it earlier. And now I would like to switch stage and let my co-chair continue.
Thank you, Lars. Good morning, everyone. So, another news in our guidelines is that decompensated heart failure replaces the term acute heart failure. And this is in line with the universal definition of heart failure, and it's basically because, as all we know, signs and symptoms of heart failure in this setting can have an acute or gradual onset, leading to a heart failure hospitalization or emergency department visit or an unplanned ambulatory visit requiring treatment. Importantly, the compensated heart failure includes both worsening of pre-existing heart failure or de novo heart failure. In the diagnostic flowchart, NT-proBNP has a major role, coming before other examinations like echocardiography to rule out the compensated heart failure, of course, except for those conditions where we have a high suspicion of the compensated heart failure or emergent or urgent situations like cardiogenic shock or pulmonary edema. Identification and treatment of acute causes is still based on the CHAMPIT acronym, and also the classification based on clinical presentation is still valid. So we have 4 phenotypes: cardiogenic shock, acute pulmonary edema, decompensated left-sided heart failure, and decompensated right-sided heart failure. So a slightly change in nomenclature requiring different initial management. Regarding the management of the congestion, we have updated our algorithm. So as a first step, we obviously have a IV dose of loop diuretic. The recommendation is still class 1, and the level of evidence is regraded. As mentioned by Lars, according to the new regrading rules by ESC, so we have a level A instead of C. And this is because this is a typical example of a treatment with an obvious efficacy. So more than 90% of our task force voted yes for this recommendation. So after this first step, we have to evaluate the diuretic response. We can do that by looking at the urinary output, or as an alternative, looking at the urinary spot sodium. And this is now formalized in a recommendation, class 2B level of evidence V1, based on the results of the PUSH-AHF trial. If there is no sufficient diuretic response, we can double the dose of loop diuretic, or as an alternative, we can consider to use IV acetazolamide or oral hydrochlorothiazide based on EGFR. So these drugs should be considered in patients with fluid overload previously treated with loop diuretics to reduce congestion, 2A level of evidence B1. But the most important news here is the early utilization of these drugs in our decongestion flowchart. In addition, we have this new recommendation for the in-hospital initiation of SGLT2 inhibitor, which is recommended not only as a part of FMT in patients hospitalized for decompensated heart failure, but also as a tool to enable decongestion. So class 1 level of evidence B, based on the results on many randomized controlled trials summarized here in this meta-analysis. Regarding cardiogenic shock, we have some new recommendations. These are probably the 2 most important ones. One on multidisciplinary shock team to recommended for patients candidates for temporary MCS, class 1 level of evidence C, and a macroaxial flow pump should be considered in selected patients with cardiogenic shock post-MI, selected according to criteria used in the denture shock trial and consequent meta-analysis, 2A level of evidence B1. Advanced heart failure, this is now defined, as mentioned by Lars, as stage D heart failure. And in this chapter, we have tried to emphasize the importance to early refer patients with advanced heart failure or at risk of developing advanced heart failure to an advanced heart failure center. We have updated our algorithm and we have tried to simplify it, reporting some easier criteria to identify patients at high risk. So in addition to the I need help criteria, we have this rule of 3 criteria. And this early consultation is reported in this new recommendation, class 1 level of evidence A. Even in this case is an approach with an obvious efficacy. So early consultation with an advanced heart failure center is recommended both in patients with advanced heart failure and at risk of advanced heart failure without major contraindications to heart transplantation or LVAD. And we have an upgrade in the class of recommendation for LVAD. This is still a level C because this is mostly based on registries. LVAD is now recommended for selected patients with advanced FREF despite FMT and GDIT. So is similar to the heart transplantation recommendation, which is unchanged, and these recommendations are reported in the updated algorithm for the management of patients with advanced heart failure. Regarding comorbidities and specific conditions, topics covered in other guidelines are not included in details in these guidelines, so I will show you in the next slides only some important concepts reported for topics that we have covered in detail in our document. Regarding non-cardiovascular comorbidities, obesity, we have this new recommendation for semaglutide and tirzepatide should be considered for patients with symptomatic heart failure, at least 45% of ejection fraction, obesity regardless of diabetes status, to reduce body weight and improve exercise capacity and quality of life. 2A level of evidence B1 based on 3 randomized controlled trials. Regarding cardiovascular comorbidities, we have some news regarding guideline-directed interventional therapies. So we have a new indication, a new recommendation, 2A level of evidence B for AV node ablation in association with CRT. And we have an updated recommendation for catheter ablation for AFib with specific criteria that should help cardiologists in selecting these patients for this kind of procedure. Regarding coronary artery disease, we have a new algorithm that should help cardiologists in selecting patients for revascularization. And as you can see, FMT has a major role before revascularization, is recommended. Heart team has a major role regardless of the heart failure phenotype and clinical presentation. And for selected patients with specific characteristics, so multivessel disease and low ejection fraction, CABG remains the first choice. Regarding secondary mitral regurgitation in patients with FREF, we have updated our algorithm according to in line with the valvular heart disease guidelines. So we have tried to emphasize the importance to optimize FMT and implant a CRT if indicated before any intervention on the valve, and we have provided specific criteria to select patients for transcatheter therapies. Finally, regarding specific condition, we focused on cardiac amyloidosis, because this is not covered by other guidelines, so we have a new diagnostic and treatment flowchart. In the diagnostic part, we have tried to report in detail how to phenotype these patients, how to reach a correct diagnosis of cardiac amyloidosis. Regarding treatment, we have an updated recommendation, class 1 level of evidence A, for patients with transthyretin amyloidosis, not only for tafamidis, but also for new drugs, vutrisiran or acoramidis, that are recommended in these patients to reduce the progression of symptoms and the risk of cardiovascular hospitalization and all-cause death. So for further details and additional and revised recommendations on these topics and on other topics, we strongly recommend you, class 1, to attend all the other sessions related to these guidelines today and tomorrow. Thank you for your attention.